Hi everyone, welcome to researchmd.com. Another great presentation today. All our presentation is under 9 minutes with all the facts. Today our topic again, irritable bowel syndrome. Very important topic. My name is Pramil. Cheriyath. I'm a program director, internal medicine residency, transitional residency. I teach medical students and residents on a regular basis. I'm also director of research and I hold 2 assistant professorships at 2 major medical schools. Let's get into our topic. So today our topic is about irritable bowel syndrome. So let's go into the definition. A symptom-based gastrointestinal disorder, right? Chronic or recurrent abdominal pain or discomfort with altered bowel habits. In the absence, I think the main point is in the absence of other causes. So it's very important to rule out the other causes before you say the patient has irritable bowel syndrome. Mainly 3 types everybody know. One is diarrhea predominant, constipation predominant, and something called the third one, kind of mixed. You can have diarrhea and constipation, okay? So, epidemiology, women, more common, most often affect people with age 20 to 30 years, usually age less than 50 years old. So if you look at the prevalence, 14% in women and 8.9% in men all over the world. So what are the risk factors associated with it? Let's look at it. Gastrointestinal infection, anxiety, smoking, frequent alcohol consumption, psychological, physical stress, history of childhood abuse, family history of IBS, GERD, dysmenorrhea. And then pathogenesis, if you look at it, still like a lot of, the hypothesis, like what exactly, so what are the most common finding in the IBS? There's always like altered gastrointestinal motility, visceral hypersensitivity, hyperalgesia, and then altered permeability of the gastrointestinal mucosa and psychosocial aspects. All of that. So let's look at the symptoms, okay? Typical symptoms present greater than 6 months. It's very important, 6 months, okay? Abdominal pain or discomfort including bloating, distension, tension or hardness, and abdominal pain or discomfort related to defecation, altered bowel frequency like diarrhea, constipation, altered stool passage, straining, urgency, incomplete evacuation. Symptoms triggered after eating, there's passage of mucus, nausea, lethargy, backache, and bladder symptoms. Those are the very common symptoms on the patient. So how do you diagnose? So 2 criteria you have to know. One is like NICE criteria and the other one is the Rome 4 criteria. Let's talk about the IBS NICE criteria, okay? Again, IBS diagnosis greater than 6 months of both pain or discomfort relieved by defecation or associated with the changes in the bowel frequency or stool form, and at least 2 of the following. One is altered stool passage. The other one is abdominal bloating, distension, tension, or hardness. Symptoms may worse by eating and passage of mucus in the stool. So let's look at the Rome 4 criteria. You got mainly like, the first thing you have to do is like, recurrent abdominal pain at least 1 day per week on average for the past 3 months, associated with the 2 or more of the following. What are the 2 or more? Like 1, onset of symptoms related to defecation, onset of symptom associated with the change in frequency of stool, onset of symptom associated with the change in the form of stool. Okay, if you have that, you go to the next step. Where the above criteria fulfilled for the last 3 months with the symptom onset at least 6 months. Now you have to look at the symptom of onset. Is it at least 6 months prior? Then you have the diagnosed IBS. Then you be with the diarrhea predominant, IBS-D, constipation predominant, IBS-C, mixed, IBS-M. Okay, if you don't have any of those, then you can say like does not meet the criteria IBS. Now let's look at the sensitivity and specificity. Very important statistical term, 75% and 80%. So pretty good, right? Treatment, the main thing is the lifestyle changes. Dietary adjustment is also very good. Plenty of fluid, high fiber diet. Avoidance of grass-producing food like beans, onions, and prunes. Fermentable short-chain carbohydrates, lactose, and avoid the gluten, to go for a gluten-free diet. Physical activity, again, stress management also very, very important. Identification of stress factors and relaxation therapy, all that. Now let's look at the medication therapy. Okay, if it is diarrhea predominant, antidiarrheal is beneficial like loperamide, rifaximin, antibacterial agent also, alocetrone. Those are the 3 things if it's diarrhea predominant, okay? And then is constipation predominant, you can do like soluble fibers, bulk forming like psyllium, osmotic laxative, and lubiprostone, chloride channel activator. Now, if it is cramping pain, you can use the antispasmodic dicyclamine, hyoscyamine, and tricyclic antidepressant, amitriptyline, nortriptyline also has a role in it. When you look at the psychological therapy, there's a treatment, cognitive behavior therapy is also useful for IBS. These are the references. We have taken the pictures from Thank you so much for watching. We'll be back with another presentation soon. Thank you. Bye.